So good morning students. In this short video we will see what are the topics to be revised for the cardiovascular system, CVS physiology. The first is the properties of cardiac muscle. The properties first is the excitability, that is bathmotropic effect. The heart muscle is excitable like any other muscles, and this excitability you call it as bathmotropic effect. And second is autorhythmicity. It is nothing but the self-excitation of the SA node that is acting like a pacemaker, and the muscle will generate its own rhythm. Okay, so this rhythm of impulse generating is on its own. That is the main part of the life to continue. So that is the self-excitation that causes the autorhythmicity. And third is the conductivity. So heart muscle have a specialized conducting system that conduct the impulse generated from SA node through all the atrial muscle and ventricular muscles. So from SA node through internodal pathways, the impulse will be conducted to the AV node, and from the AV node it will be conducted to the bundle of his, then right bundle, left bundle, then Purkinje fibers, then to the ventricular muscles. And this system is called as conducting system of the heart, and this property is called dromotropic effect. And next is the contractility. So it is we have to discuss about the force of contraction, how the heart muscle contracts. Like skeletal muscles, it is also a striated muscles where we have actin, myosin, and goes for contraction. And this contractile property is altered by many factors. Okay, and one important factor is the preload that we will be talking as Frank's Stalling law. So the end diastolic pressure or the filling due to the end diastolic volume that increases the initial length of the fiber, and that causes the force of contraction, and this occurs within the physiological limits. So this was told by Frank Stalling as Frank Stalling law. So this we have to talk in the discuss in the contractility part. The next comes the refractory period. So refractory period is something the heart is not, the cardiac muscle will not respond to a second stimuli, whatever the strength of the stimuli. Okay, so in other words, it will not go for any re-stimulation. It is refractory to re-stimulation. So once the first action potential causes the contractile process, after the contractile process gets over, the muscle will respond to the second stimuli. And this property of refractory period is of two types: absolute and relative. Absolute is whatever the strength of the stimulus, there is no response. And relative refractory period is if the strength of the stimulus is increased, there will be a response. But in cardiac muscle, there won't be any second response because of the presence of a long plateau phase in the cardiac muscle potential curve. So this cardiac muscle potential curve you have to discuss in the contractility also. Okay, it is nothing but like action potential of skeletal muscle. Here also we have cardiac muscle potential, where we have depolarization that is due to sodium influx, then repolarization, a little repolarization by the potassium efflux, then there will be plateau phase will be there, and this plateau phase will be the curve will be like this. The plateau phase is due to the opening of calcium channel, long lasting calcium channel that maintain the depolarization, and after that there will be repolarization will be there, and that is due to as usual by the potassium efflux. Okay, so this plateau is very important, and this is the reason for the long refractory period in the cardiac muscle. So that's why because of this only the muscle cannot be tetanized. Okay, so tetani cannot occurs in cardiac muscle. The next is you have to talk about the cardiac output. So in cardiac output, the definition of cardiac output, you have to know amount of blood ejected by each ventricle per minute, and it is a product of stroke volume and heart rate. Stroke volume is amount of blood ejected in per each beat. Okay, in each beat, and it is around 70 ml, and heart rate is 70 beats per minute. So 70 into 70 you will get 4900 ml, around 5 liters, that is the cardiac output. And here comes the factors regulating the cardiac output. What are the factors affecting the stroke volume and heart rate? It is going to affect the cardiac output. So factors affecting the stroke volume is of preload, which is nothing but the end diastolic volume. Then afterload, which is the peripheral resistance or the aortic pressure. And the third factor is the muscle contractility. So the preload or the end diastolic volume, you have to we have to discuss the factors affecting the end diastolic volume, like the venous return, the ventricular muscle compliance, then atrial pump. Under venous return, you have to discuss the skeletal muscle pump from the lower limb, that is the pump that will squeeze the blood from bottom to top. Okay, so this squeezing is big and the blood is flowing in one direction because of the venous valves in one way. And we have the abdominal pump. Here also, due to inspiration, the diaphragm is moving down, increasing the abdominal pressure that squeeze the blood from the abdominal veins to the upwards. And third is the thoracic pump. During inspiration there is an expansion of the chest, and there will be fall in the pressure in the central veins, and that causes a suction and blood will be pulled upwards. Okay. So thoracic pump, abdominal pump and skeletal muscle pump all will increase the venous return. That is going to in turn increase the end diastolic volume. And ventricular muscle compliance is the ability of the ventricular muscle to expand, and this may be restricted by some diseases of pericardium, which is covering the heart muscle. And next is the atrial pump. Here the pumping action of the atrium that will causes the ventricular filling, and that will affect the end diastolic volume. So these are the three things we have to look in the end diastolic volume. Okay. Next comes the stroke volume is directly proportional to the end diastolic volume. Next is the afterload. So afterload is stroke volume is inversely proportional to afterload. Afterload is nothing but the resistance offered by the aorta, and this resistance depends on two factors. One is the vessel diameter. When the diameter is very narrow, it is going to give resistance. Second is the viscosity of the blood. Say in polycythemia, where the viscosity is more, the afterload will be more. So stroke volume is inversely proportional to afterload. And third property is the muscle contractility. So stroke volume is directly proportional to the muscle contractility. So more the muscle contracts, more will be the force of contraction, and more will be the stroke volume or the cardiac output. And this contractility depends upon the muscle mass. Okay, and hypertrophy muscle will contract more, and also depends on the autonomic nervous system. Sympathetic will causes more contraction of the heart muscle, cardiac muscle. And hormone thyroid, it will activate myosin ATPase, it will increase the contractility. And some drugs like digitalis, that will increase the contractility. So whatever factors that is increasing the contractility, they are called positively inotropic. So whatever factors that decrease the contractility, they are called as negatively inotropic. So inotropic effect is referring to the contractility property of the cardiac muscle. So next is the cardiac cycle. So in cardiac cycle, you have to talk about in cardiac output, we have to talk about one left out is regulation. So regulation is of two types, heterometric and homometric. Heterometric means change in length will change the cardiac output. So here comes the Frank-Starling law. So what it says is the initial length of the muscle fibers is directly proportional to the force of contraction. In other way, force of contraction is directly proportional to the initial length of the muscle fiber within physiological limits. Here the initial length of the muscle fiber is dependent on the end diastolic volume. Okay, so the end diastolic filling or volume that is going to stretch the length of the fiber, that is going to affect the force of contraction. So this was called as the Frank-Starling law. So this type of regulation where the change in length is changing the cardiac output is called heterometric regulation. All other factors like the autonomic nervous system, sympathetic activation, the afterload, which is the aortic resistance or the peripheral resistance, and the drugs, the hormones, all this regulating the cardiac output, and these factors coming under homometric regulation, where the change in length is not the deciding factor. So that is why it is called homometric regulation. So here you have to discuss about the afterload and the muscle contractility. So we have finished the cardiac output. Then we go for the cardiac cycle. So in cardiac cycle, you have definition of cycle. It is a sequence of event between two heartbeats, successive heartbeats. And here the events refers to two types of events, electrical and mechanical event. Electrical event is depolarization and repolarization. Mechanical event is contraction and relaxation. Usually the depolarization leads to contraction and repolarization leads to relaxation. And the duration of cardiac cycle is 0.8 seconds. And this occurs in atrium, it is called atrial cycle. In ventricle, it is called ventricular cycle. For study purpose, we will take ventricular cycle. In ventricular cycle, we have two types, two parts. One is the systole and diastole, that is contraction and relaxation. And systole is of three. One is isovolumetric contraction, rapid ejection, and slow ejection. And diastole is of 5 phases: protodiastole, isovolumetric relaxation, rapid filling phase, slow filling phase, and last rapid filling phase. So the event or story starts like that. See, once the blood is filled, filling the ventricle, once the ventricle is filled with the blood, the ventricle will go for contraction. So the first part of the contraction is called isovolumetric contraction, where both the AV valve and semilunar valves are closed, and there is an increase in the pressure. And the next is rapid ejection. So once the pressure is increased, there will be opening of the semilunar valves, and blood is ejected from the ventricles to the aorta and the pulmonary trunk. And this ejection gets slowed down because of the increase in the pressure in the aorta and the pulmonary trunk, and that phase is called slow ejection phase. So after the full ejection, the valve gets closed, semilunar valves gets closed. Next is this closure marks the beginning of the ventricular relaxation or diastole, and this phase is called protodiastole, where the closure of the aortic valve is of prime importance, and it was taken as the protodiastole. And the first phase here in the relaxation is protodiastole, and the second is the isovolumetric relaxation, where the ventricle started relaxing, and there is actually blood, all the blood have been ejected already, so there is no much blood, and this relaxation causes fall in the pressure in the ventricle, and in the meantime the atrial pressure will be increasing, and this causes the opening of the AV valve, and you go for the third phase, which is called rapid filling phase, where the ventricle is filled with blood rapidly. After this rapid filling, there is a slow filling, where the filling gets slowed down because the pressure in the atrium start reduce. So there is a fall in the pressure. So that causes this filling to get slowed down. And the last phase is called the last rapid filling phase, where the atrium will contract and the filling occurs. So usually 80% of ventricular filling occurs in the rapid filling phase and slow filling phase, and remaining 20% occurs in the last rapid filling phase, which coincides with the atrial systole. So these are the phases of cardiac cycle. Then comes the blood pressure. So the blood pressure is a lateral pressure exerted on the walls of the artery, and this pressure normally we are recorded as maximum as 120 mm of mercury systolic blood pressure, and minimum as 80 mm of mercury, which is called the diastolic blood pressure. And pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. And in blood pressure, you have to talk about the regulation of blood pressure: short term, intermediate term, long term. Short term is regulated by baroreceptors, chemoreceptors, CNS ischemic response. Intermediate term is capillary fluid shift and stress relaxation, and long term is regulation by the kidney, which is called renin angiotensin mechanism. So in short term, baroreceptor means these baroreceptors are located in the aortic arch and carotid body, and when BP increases, the baroreceptor gets stimulated, and their signals sent to the medulla through the 9th and 10th nerve. And in the medulla, the vasomotor center, which is a center that is responsible for the increasing the blood pressure, and the vasomotor center is depressed. Okay, there is suppression of the vasomotor center, and there will be fall in the BP. So stimulation of baroreceptor, inhibition of the vasomotor center, fall in the blood pressure. In chemoreceptor reflex, there is the flowchart starts fall in the blood pressure, so there is a fall in the blood flow, and that causes hypoxia, and this stimulate the chemoreceptors, and the chemoreceptors in turn will send signals to the vasomotor center, and they will activate the vasomotor center and increases the blood pressure. And the third is the CNS ischemic response, which is a last ditch stand. It is a last chance for the body to increase the blood pressure. And here is low, very low BP. Say the BP will be, the mean arterial pressure will be very low as 30 or 40 millimeter of mercury, and this low BP causes a very low blood flow to the vasomotor center, and there is a direct stimulation of the vasomotor center takes place, and there will be an intense vasoconstriction throughout the blood vessels in our body through the sympathetic system, and try to increase the blood pressure. So this is called CNS ischemic response. And these are the three things you have to talk in the short term regulation of BP. In intermediate term of regulation of BP, one is the stress relaxation. When there is an increase in the blood flow, stretching of the smooth muscle and causes relaxation, and that causes fall in the BP. And capillary fluid shift, when there is an increase in the blood flow in the capillaries, some amount of fluid will be shifted from inside the blood vessel to outside, thereby the blood volume will be reduced and blood pressure will be reduced. And the third mechanism is the long term regulation, that is by the kidney, where decreased blood flow to the kidney will stimulate the juxtaglomerular cells to secrete renin, and this renin will activate the angiotensin II, and this angiotensin II will increases the blood pressure by causing vasoconstriction, and this was called renin angiotensin mechanism. So these three regulation you have to see in blood pressure. And the final is the ECG. So ECG, electrocardiogram, we are recording the electrical activity of the heart from the surface of the body, that is from the skin, and this ECG measured using leads. Leads are the pair of electrodes, and we have two types of leads, unipolar leads and bipolar leads. Unipolar leads record the potential at that area, whereas bipolar leads will record the potential difference. This is some physical concept, and here we are using the unipolar leads as augmented leads and chest leads, and bipolar leads are limb leads, and limb leads of three types, L1, L2 and L3, and augmented leads are AVR, AVL and AVF, and chest leads are V1, V2, V3, V4, V5, V6. Now we record using these leads, and the waves we are getting are of P wave, these are the which is referring to the atrial depolarization, QRS ventricular depolarization, T wave ventricular repolarization. So I just try to give in a nutshell, and in ECG you have to learn about the Einthoven law, that it says that the potential in lead 2 is equal to lead 1 plus lead 3. So lead 1, 2, 3 are called limb leads. Okay, they are coming under bipolar leads, and this bipolar leads will measure the potential difference. Okay, so say L1, that is between the left arm and right arm, L2 between the left leg and right arm, and L3 between the left leg and left arm. So these are the limb leads. Okay, so I just try to cover, and you also go through the remaining topics also. Okay, thank you.